Good morning. Good morning to all of you. Today is a special day because we have a great speaker amongst us, Dr. Madhu. She is well known all over India and abroad for her dedicated work in mycology. And she is keeping the tradition of Madras school, where the mycology has been a very fascinating and dear subject for all of the Madras school. However, she has made a contribution to modern modern dermatology with her contributions in mycology. And she is very active in mycology, and she has contributed a lot into the field of mycology. And presently, she is a very busy person, giving lectures all over India as well as outside. And we are fortunate to have Dr. Madhu with us for today's webinar. And she will be talking about dermatophytosis and candidiasis. And dermatophytosis, as you know very well, that it is a rather an epidemic in India with lot of different types of presentations and lot of different challenges that occur in the field of dermatology, in the field of mycology. We clinicians, especially those who are practicing dermatology, as well as the students who are learning dermatology, are facing so many unanswered questions in mycology. So Dr. Madhu is going to enlighten us on various aspects of dermatophytosis. At the very same time, she has agreed to talk on candidiasis. This is also a very important area, and many of us have very little knowledge about candidiasis, and it is, again, it's a very important, especially when there is immunosuppression due to various drugs and due to various diseases. Candidiasis forms a major part in the management. So learning mycology, especially dermatophytosis and candidiasis, forms a very important part in managing dermatologic patients. So we will learn from the very expert, Dr. Madhu, about various aspects of dermatophytosis and candidiasis.
Respected sir and my dear friends, good morning, and my sincere apologies for this 10 minutes delay, which was due to unavoidable circumstances. And sir, I always deem it, consider him as an epitome of humility. So thank you all so much, sir, for your kind words of introduction, but it's really not that so much so. So it is just that I love mycology, and in a little way, I'm trying to do something. Thank you, sir. Now, having said that, let me take you into this world of dermatophytosis. So if you consider dermatophytosis as such, world over, it is said that it is affecting almost about 25% of the world population. And if you see how many can be asymptomatic carriers, literature says it can be as high as 30 to 70% of adults can be anytime asymptomatic carriers. And nevertheless, it could have been almost 10 to 20% of the population could have acquired the infection sometime or the other. And we all know about the regular predisposing factors that contribute to dermatophytosis. And the point to be noted is there has been an increase in the incidence of drug resistance in patients with dermatophytosis. And earlier, we were only talking about the dermatophytes belonging to 3 genera, the Trichophyton, Microsporum, and Epidermophyton. Now, the recent classification mentions another 4, namely the Parophyton, Lopophyton, and PAS, of course, is supposed to be, again, gold standard for the nail infection. And when you have a fluorescent microscopy, that is good enough actually. And if you have to talk about the modern methods, of course, I did mention about the MALDI-TOF and the PCR and the dual flow cytometry also. Collection of specimen is very, very, very important as far as the nail is considered. So always try to take a clean sample, because you can always have the local contaminant, which can be false negative results. Okay. And if you want to do a culture, of course, there should have been a washout period of at least 2 weeks for topical and 4 weeks for systemic antifungals actually. So to all of you, and you know that the onychomycosis is less common in children, obviously because of the faster nail growth and of course the lower surface area, and they're of course less prone for trauma as well. And the predisposing factors for onychomycosis, all of you would be well aware of, but please remember poor peripheral circulation as well. Elderly patients, trauma prone, water work occupations, and poor peripheral circulation, as in sclerosis, systemic sclerosis actually. So when you're doing of course, the latest investigation of confocal laser scanning microscope is also there. One thing is about the culture in the non-dermatophyte onychomycosis. If it is dermatophyte, it's easy. Non-dermatophyte, we would want to know whether it's a contaminant or a true infective agent. So that is why we say this criteria has to be fulfilled. So you have to have diagnosed an NDM in KOH. You should have had an isolation culture. For culture, again, you should have had at least 5 out of 20 inoculums getting the same organism, or repeated isolation of 3 consecutive times, you should get the same organism. And of course, histopathology can be further additive to it actually. And you all must be well versed about the dermoscopy patterns in onychomycosis. You see the spike pattern, and you can see the longitudinal striae of different colors, that is the aurora borealis. And of course, the other patterns actually. For want of time, I'm not mentioning everything. So how are you going to treat a patient with Tinea unguium? When it comes to Tinea unguium, it is always dermatophyte caused infection, right? So terbinafine is going to be the drug of choice. Okay. Now itraconazole pulse is for, it should not, actually the heading should have been onychomycosis. I'm sorry, it's Tinea unguium. So Tinea unguium, I would prefer to give terbinafine. Terbinafine in the continuous therapy of 250 milligrams once daily for two months for fingernails and 3 months for toenails is what is mentioned in the book. You can always continue it for a little longer time. No harm. And in the case of onychomycosis, that is a non-dermatophyte onychomycosis, you start giving itraconazole pulse, wherein we talk about 200 milligrams twice daily for 1 week, once a month, and fingernail 2 pulses and toenails 3 pulses. Now, how are you going to monitor the response? You will see that the height of the subungual hyperkeratosis starts reducing, and the new nail starts forming, and the existing discoloration of either a blackish or brownish or yellow discoloration, that also supposed to be improving. And as far as treatment of onychomycosis is considered, the success rate can be much higher only when you use it in a combination with topical nail lacquers. So topical, you have the 8% cycloperoxylamine nail lacquer, which has to be applied every day. We normally say Monday to Saturday it can be applied, and Sunday the nail polish remover can be used and the debris can be taken off the coating. And if you're using 5% amorolfine nail lacquer, that has to be used weekly twice actually. And of course, we do earlier days, they were talking about teoconazole 28%. And if you have a single nail involvement, and sometimes, a patient does not want to apply medication for a long time, we talk about the medical avulsion of nails, wherein you use 40% urea or 50% potassium iodide or 30% salicylic acid. And of course, it's not what's new for us, probably. It is still not in India, but you do have this efinaconazole 10% and tauberol 5% being used in the Western countries, which are supposed to have a better cure rate. And tauberol is basically an oxabarol, which is supposed to inhibit the lusyl tRNA synthetase, and it decreases the protein synthesis. Now, this can be a short note for you all when you have a recent advances paper, actually. And of course, people do talk about, lasers being used for onychomycosis, and the CO2 laser and the dual wavelength laser, and of course, photodynamic therapy and 5-aminolevulinic acid. Of course, I really do not have experience with lasers in onychomycosis. Okay. And with that, we have completed dermatophytosis, and we move on to candidiasis. Now, this is, of course, not a big topic though. And quite often you would have come across a patient who is 40 years old male who comes with, oral candidiasis, and then you suspect HIV positive and the CD4 counts become low. Or there could be a patient who comes with vulval itching, and you do a blood sugar, it becomes 286 or, higher levels than that. Or it could be sometimes when a patient who's going to be, more often working in a sun-exposed, climatic conditions, and, itching in the gluteal cleft, intertracheal groin or gluteal cleft. And somebody who's doing the water work, gardening or housemaids with, the swelling of the finger digits. Now, all these are going to be Candida. Now, Candida is considered as the vulture of the fungal world, and almost around 150 to 200 organisms are there, 200 species are there. Luckily for us, it is only the 5 major ones which are going to be of medical importance. And these are responsible for causing infection in almost 90% of patients. And the Candida non-albicans species are on the rise, like Glabrata, Tropicalis, and Parapsilis, and cruzi. And Candida cruzi is one drug which is supposed to be having a primary resistance to fluconazole, which means if you're going to have an disseminated candidal infection due to cruzi, we really have to go for echinocandins and not azoles actually. So basically, these are commensals, isn't it? So again, predisposing factors could be the extremes of age and pregnancy and menstruation, and not to forget the nutritional factors. And of course, you can talk about the mechanical factors, the local occlusion and the dentures, and of course, the systemic immunocompromised situations that can be predisposing to candidiasis. And we are aware about the cutaneous component of flexural candidiasis. You can have candidal granuloma, the chronic paranoia, and of course, congenital and neonatal candidiasis. Now, between congenital and neonatal candidiasis is supposed to be, more of a major concern for us. And you will have to ask for history of any premature rupture of membranes and whether there could be an amniotic leak or foul-smelling amniotic liquor. And of course, the baby presents with lesions, papules, and baby will be toxic. And the skin which is tender, that is something which can be really, pointing towards congenital candidiasis. Whereas the neonatal candidiasis is, it's most often it's just an oral thrush, and it's more often a well baby, and you would just have a minimal white patch probably over the tongue, which responds to simple clotromazole mouth paint actually. And of course, the mucous oral candidiasis and vulvovaginitis and balanopascitis. And please do not forget chronic mucocutaneous candidiasis, wherein it could be associated with immunodeficiencies and endocrinopathies and autoimmune conditions. And the components will be persistent oral thrush, the cutaneous component, and of course, the chronic paranoia with the well. And somehow almost more than 90% of the patients can have oral candidiasis during the course of the infection. And basically, it is supposed to correlate with CD4 count of less than 200 cells per cubic millimeter. And the symptoms can be really varied. Like it could be just a silent asymptomatic colonization, or it could be a florid presentation as well. And I did mention about the non-albicans candida emerging as more often as causative agents actually. And the resistance to fluconazole. Now, once there is a proven resistance to fluconazole means we cannot give itraconazole also. You'll have to go for echinocandins. Now, what are the factors which will affect the prevalence? Of course, obviously, the course of the HIV infection, the CD4 status, the immune status of the patient, and the underlying diabetic conditions. And of course, the local oral hygiene is also very important. And of course, talk about the other high-risk behavior. So these are very important to contribute to the prevalence. So for oral candidiasis, we do know about the most common one is the acute pseudomembranous, isn't it? Acute pseudomembranous candidiasis, or you have the chronic pseudomembranous oral candidiasis. And when the patient has used antibiotics, a broad spectrum antibiotics, and then, the patient comes out with a burning sensation in the tongue. And, that is called as the antibiotic sore. Or when a patient is using denture, then you call it as denture stomatitis. That is acute atrophic. When it comes to antibiotic sore, that is acute atrophic candidiasis. And if it is going to be denture stomatitis, that is going to be a chronic atrophic oral candidiasis. And of course, you can have the median rhomboid glossitis and Purlish, and you can have the chronic plaque, the hypertrophic type. So these are the other types of candidiasis actually. So how are we going to treat? In candidiasis, the most important thing is you have to take care of the predisposing factors. That's very, very important. And if it is just localized, a topical, the clotrimazole mouth paint, or people do talk about the chlorhexidine mouthwashes and the nystatin suspension also. But when we have to give systemic, especially if it's going to be a diabetic or immunocompromised state, there are different dosage regimens that are available for fluconazole. People prefer to give 100 milligrams daily for 2 weeks, or fluconazole thrice weekly for 2 weeks, or fluconazole 150 milligram daily for 2 weeks. If there is you have a patient with pemphigus vulgaris with an involvement of not only the oral mucosa, sometimes pharyngeal and esophageal, you might have to go for a little longer duration. And of course, itraconazole again, 100 milligrams once daily dosage for 2 to 3 weeks is also being followed. And sometimes with the immunosuppression, people do consider 200 milligrams OD also for a period of 2 to 4 weeks. Now, this decision has to be taken according to the clinical status and the comorbid condition that is present in your patient, actually. So moving on to vulvovaginal candidiasis. Now, this is again one of those most important factors. And many a times we do have patients coming with vulvovaginal candidiasis because it is said that almost 75% of all women can experience vulvovaginal candidiasis in their lifetime. And most often it is albicans that is important cause for VVC actually. And of course, you do have to think about the intrauterine device and the other immunosuppressions also as the predisposing factors for vulvovaginal candidiasis. Now, when do you call it as recurrent vulvovaginal candidiasis? When you have 4 or more episodes in a year. And these factors like the practice of using gentle cleansers and dutchers or probably a frequent intercourse or the poor personal hygiene. And then, of course, the hormonal changes and the immunosuppressed conditions all contribute to recurrent VVC. And in the case of Dermatophytosis, of course, 30 to 35% of balanitis is because of candidial. And these are the predisposing factors, which you're all well aware of, actually. VVC and Dermatophytosis. And many a time, when you have a patient who reports to you with vulvovaginitis, you can always go ask for a screening for the glycemic status in the partner as well. And sometimes you would be just able to pick up a diabetic in the partner. So always, please remember to have a blood sugar done, HbA1c done for those patients who report to you either with vulvovaginal candidiasis or Dermatophytosis, not only for the patient as well as for the partner also. And of course, we do give the clotrimazole and meconazole cream, and you have the suppositories which are available. And the regular dosage of fluconazole 150 milligrams is your syndromic approach. Otherwise, the complicated cases, we do give 1, 3, and 7. So 1, 3, and 7, 3 doses of fluconazole is also being given actually for 1 or 2 weeks. And if you're going to give itraconazole for recurrent vulvovaginal candidiasis, you would like to give 200 milligrams per day for 3 days, followed by 200 milligrams a day on the first day of menstrual cycle, for a period of 6 months, actually. As far as the cutaneous candidiasis goes, we know about the obesity, especially, or sometimes poor personal hygiene. So keeping the area dry is most important. So all the flexures are prone for cutaneous candidiasis. Not to forget the web spaces and not to forget the Ehrlichia interdigitalis blastomyces etica. So all the imidazoles have a very good action against candida. So it is always nice to use ketoconazole, fluconazole, meconazole, econazole, anything which is going to be affordable for the patient. So a twice daily application, keeping the area dry is very important actually. And of course, systemic is definitely required if it is going to be severe immunocompromised. Yeah. So this is about the neonatal candidiasis, and here you see the chronic mucocutaneous candidiasis, which I had mentioned earlier, and candidial granulomas, the infantile gluteal granulomas. And so that is the spectrum actually. And chronic paranoia, I think, as far as chronic paranoia is considered, again, please find out if there are multi-digit paranoial involvement. You have to ask for diabetic status also. I think, yeah, right. Multiple digits, you have to rule out diabetic status. You will be able to see that the cuticle is lost and there is nail fold edema, posterior nail fold edema, or sometimes you can have the lateral nail fold edema also. So acute, you'll definitely have bacterial infection. Chronic is more often candida. So here is one condition where apart from your systemic antifungals or antibiotic, you might have to want to use a combination of antifungal with a low potent steroid like a beclomethasone. That will take care of this anti-inflammatory. That is only place where I would like to use a combination of a steroid and antifungal. Otherwise, we never and never advocate the use of topical corticosteroids with antifungal component. And over a period of 2 weeks, apart from keeping it dry, it definitely helps. And when there is a candidial onychomycosis, you try to take this specimen from the posterior nail fold. Actually, from this area, if you take, you will definitely get it as a positive for candida actually, when you're doing a potassium hydroxide wet mouth. So I think we have covered dermatophytosis and candidiasis, of course. So what is most important when we treat patients with dermatophytosis and candidiasis is that you should be really able to spend some time with your patient to take a proper history and take care of the comorbidities and the drugs that their patients are taking. Keep in mind all the drug-to-drug interactions. Counseling is very, very important regarding the following the general measures as far as dermatophytosis is considered. And please remember, you'll have to follow the rule of 2 for topical antifungals. And as far as the systemic antifungals are considered, it is not 2 weeks or 4 weeks or 6 weeks. You would have to continue it until your patient responds to the treatment. And you have to counsel the patient that this is something which you need to take for a long time, as it's not as bad as a diabetic or hypertension. But if you follow the general measures and take treatment for a period of 6 weeks or 8 weeks, depending on the drug that is being used, there could definitely be a good cure. So wishing you all the very best, wishing you all a bright career in dermatology. Thank you all for your patient listening. Thank you so much. I'm sorry if I had really exceeded the time limit also.
That's okay. That's okay. Anyway, thank you, ma'am, for a very exhaustive lecture on dermatophytosis and candidiasis. And in fact, you have given a lot of practical clues, and that would be great in further management of and their further career also.
Thank you, sir.
So, however, the postgraduates, I have a warning that dermatophyte don't take it very lightly. Also the candidiasis, that should be taken very seriously, and you have to go, as ma'am said, the general measures, most of the time we forget to advise the patient or counsel the patient. So the general measures is as important as the specific treatment. So that is what ma'am has emphasized over and over again. So general measures, simple thing. Don't share, don't use tight clothing, don't reduce weight. All these things are very, very important for the proper management. You can give lot of drugs, but if you are not adhering to the general measures, the results are going to be little difficult. So, as ma'am said repeatedly, you follow the drug treatment. At the very same time, you follow the general measures, which is very easy to apply, but very difficult to convince the people. That is one thing which I have found frequently. Don't share your clothing. That is one advice we usually give. But in fact, they all share, especially those who are in the hostels and all. They share their formites very regularly. So this should be curtailed, and you have to emphasize these facts over and over again, and you will get a good response. Thank you, ma'am, for your excellent,
Thank you, sir. Thank you so much.
excellent talk.
Thank
Thank you very much. Thank you.
you, sir. My pleasure, and thank you for the opportunity, sir.